Welcome to Conceive the Podcast, your resource for all things fertility, women's health and pregnancy, with your hosts, Jaya, Chinese medicine practitioner and Director of Natural Fertility Geelong, and me, Libby Morgan, Practice Manager and Jaya's friend. In this episode, we're talking with specialist obstetrician and gynaecologist Dr. Alex Bonner about miscarriage. Miscarriage still feels like a very underspoken about issue, considering the statistics Alex will be sharing with us. We hope this episode will help in understanding more about miscarriage and open up the conversation. The lovely Alex works at the Epworth, Geelong and Barwon Health and lives on the coast with her family. And from stalking her Instagram, I've also discovered she's a keen surfer. Welcome, Alex.
Thanks,
welcome.
Beginner surfer. Yeah.
Beginner. Still surfer. You've got a surfboard. So I just touched on your background very briefly. Can you just tell us a bit more about yourself and your path to becoming an obstetrician and gynaecologist?
Yeah, sure. So I did my specialist training at Monash Health, and then I went and worked in Gippsland for a couple of years, and then I've come over to Geelong.
Okay, let's talk about miscarriage. How common is it these days?
Sure. Yeah. So, look, it's the most common pregnancy complication. We think that 20%, so 1 in 5 of confirmed pregnancies will miscarry. So in terms of how common it is, considering how many pregnancies there are in Australia every year, it affects 100 to 150,000 families every year.
Yeah, wow. And what about recurrent miscarriage, and how do we define that?
Sure, yeah. So there is a little bit of, discussion around the definition, but recurrent miscarriage is 2 consecutive miscarriages. In some of the literature, they talk about 3 miscarriages.
That's how I've always known it to be.
Yeah, but there's some new, evidence around like doing investigations for recurrent miscarriage, that there's no difference in how often we'll find something that we can identify and treat between 2 or 3 miscarriages. So for women that have had 2 miscarriages, we just get on and have a good look at it.
Yeah, I think that's good.
Mm.
Is that sort of your group? That's how you...
Look, no, it's a very good question. I think I guess there's a difference sometimes between the way we understand a condition and then the way that it's managed, say, within the public hospital system. And because miscarriage is such a common phenomenon, they do sometimes need to limit like the number of women that they're seeing and how many investigations they're doing. So I guess that's where those limitations can come into play. So some of the public recurrent miscarriage clinics, for example, focus on women that have had 3 consecutive miscarriages, I guess because they feel like that those women are the most at need of that kind of specialist review. Yeah. But
in a private setting, it might be quite different though.
Yeah, or for a woman seeing her GP with 2 consecutive miscarriages, or seeing her obstetrician gynae, that we would start that process after 2 miscarriages. Yeah, but that's like a more reasonable approach.
What do we know about some of the causes of miscarriage?
You know, and that's a good
really
question.
A very massive question.
Well, no, and I mean, it's often the question that women ask.
Yeah.
Right? So it's almost always the first question, like, why did this happen?
Yeah, of course.
Most of the time we won't be able to give an answer. We think that probably about 50% of miscarriages are due to something genetic, so something related to that baby's chromosomes, and the mother's body recognises that there's something not normal in the way that the baby's developing, and that pregnancy will then miscarry. So we think that's about 50%.
And what about some of the other causes?
Medical problems, so underlying medical problems for the mum. We know that thyroid disease, so either hyper or hypo, so high or low thyroid hormone, can affect a developing pregnancy. Also an autoimmune condition called antiphospholipid syndrome, which is related to SLE. People might be a bit more familiar with that, which is an autoimmune condition. Yep. It's not a common condition, but it does have a strong relationship with recurrent miscarriage, a miscarriage and recurrent miscarriage.
Okay. And what about structural issues
Yeah. Yep. So
of the uterus.
Yeah. So what we call uterine anomalies. So that's the shape of the uterus. So
which is not as common, is it?
No, but it's not rare either.
Okay.
Yeah.
Yep.
So some women have, like, when they have been an embryo and developing, the way that their womb grows, they can have a septum, which means like the uterus is like a love heart shape, and then that can become even what we call two horns, or they can have like a normally shaped uterus but with another little horn coming off the side.
Or there's been some women have had two uteruses.
It's a spectrum. It can become two uteruses, two cervixes. You can have a vaginal septum, so effectively like two vaginas. Yep. It's just the way it embryologically develops. But so it's uncommon, but also uterine fibroids are much more common. Look, and sometimes they don't cause, there's just an association. So some women with uterine fibroids, which are really common, get pregnant and carry that pregnancy, no problems. But if someone's having, say, recurrent miscarriage and they've got multiple or large uterine fibroids, particularly fibroids changing the shape of the uterine cavity, that may be something that needs to be addressed.
Because there isn't a direct link between fibroids and miscarriage.
No. So is it the change in the shape when you're talking about like the septum, the split uterus sort of thing? That change can affect pregnancy outcome. Yeah,
so I think, and it's from the way in which it can affect the way in which the pregnancy implants.
Yep.
Or then down the track, how much space the baby has as well.
That can lead to problems like later miscarriage, like early delivery, so like preterm birth, and also what we call malposition, so like a breech baby, for example.
But in those early stages, it's definitely going to be about how the baby implanted that early growth.
Yeah.
And are there any other causes that are linked to miscarriage?
Sure, yes. So I guess the elephant in the room that we haven't mentioned is age, which is always a really challenging thing to talk about because it's something that we can't change. And so we think that a woman's age directly impacts her egg quality, which can increase her risk of the chromosomal problems. And so as your age increases, your risk of miscarriage certainly goes up. So after the age of 35, that risk begins to increase, and certainly at the age of 40, your risk of miscarriage when you've had a confirmed pregnancy is around 50%.
Is it really 50%?
Yeah.
Yeah, that's really hard, isn't it?
Yeah. And so I guess it's just important that women are aware of that.
Freezing eggs is a good option.
It's becoming definitely more of an option.
I think that's a hard thing, and we see this a lot in the clinic too, is that women are so healthy, they're doing all the right things, and yet sometimes they're getting a lot of embryos that don't make it in IVF.
Absolutely. So they still may have a large number or, a good or enough eggs, but it's actually the genetic material in the eggs.
Finding that good one.
Yeah, and we can't change that. Like there's ongoing research, but in terms of actual things that we can do to change the chromosomal makeup of the eggs.
And I guess that's why when we talk about improving egg quality, it only goes so far.
Yeah.
So
can't wind the clock back.
No.
Yeah, so I guess it's a similar thing that, say, younger women who are going through miscarriage will experience, but it's less often that you'll get an embryo that doesn't read the instruction manual correctly.
Yeah, exactly. So I think, as a woman gets older, that's more likely going to be the cause.
Yeah.
What sort of investigations are done after a miscarriage or available to women after miscarriages?
Yeah, great question, Libby, because that really feeds into that, why did this happen? So I guess at the time of the miscarriage, particularly for women with recurrent miscarriage, so who have had 2 or 3 miscarriages, when that question's going to be even, more important to them, they can request genetic testing on the pregnancy, which is called a karyotype, and it's a test where we look at the chromosomes in that pregnancy. And I guess that's an example of one of the tests which can be limited because of the cost of the test. So certainly women that have had 3 miscarriages, it's something that we would offer them. Women that, and I think, at Barwon Health, we're pushing for that to be after 2 miscarriages. But that being said, even for women experiencing their first miscarriage, it's something that they could request, but it just may be that they need to pay for that themselves, and it costs a couple of $100s.
And for some women, that might be just, no problem. We want to do that because we want to know.
Absolutely. And it can be, I think, often the genetic cause is something random, that it's not going to occur again, that random issue with the chromosome. So it's not necessarily going to give them information that's going to change the course of their future pregnancy, but it may just give them some type of closure to have an answer as to why this happened.
And I guess it's finding the balance too of will it give them closure, or will it make them really anxious about another pregnancy that there's not a specific treatment for that, and they're aware that happened that one time.
Absolutely. And because the absolute majority of women who experience that, or couples that experience that, there's nothing wrong with their genetic makeup. It's just something that's happened randomly by chance. So
which is a hard pill to swallow.
Yeah, and I think so in our practice, we talk to women about that, and some women may choose not to do that testing, and for other women, I think we just need to really individualise it at that point.
Yeah, absolutely.
But Libby, sorry. So that's one thing at the time of the miscarriage that women can consider. But then I usually recommend doing some background tests, either through their hospital clinic or with their gynecologist or with their general practitioner, to make sure that they don't have underlying thyroid disease. That's when you can do that testing. They can also do the testing for antiphospholipid syndrome. And in the setting of recurrent miscarriage, they can ask for a karyotype of themselves and their partner. And so that's looking for something called a balanced translocation. So they may be very, healthy individuals, but if they have a balanced translocation, what that means is they have an extra bit of chromosome on one of their chromosomes, but it's balanced, so it's on both of their chromosomes.
So there's a bit there that shouldn't be there.
Yeah, but they've got those 2 bits.
Yeah, so they're kind of like swapped hands. Is that right? No.
It's quite complicated.
No, I can see it in my mind, but I can see Libby's face, and I'm trying to explain it.
So we have 2 sets of every chromosome. And then for someone with this condition called a balanced translocation, they have an extra little bit on the top of both of them. Okay.
Yeah.
And that's in all of their cells. But then when they conceive, when you make a pregnancy, you share one of each of the sets of the chromosomes. But you're sharing your chromosome that's got the extra bit on it, and your partner doesn't have that. So then it becomes what we call unbalanced. I'm no geneticist, I guess. So I don't have an anecdote to make this easier.
Complex topic.
But it just increases the risk of miscarriage, and actually increases the risk of chromosomal problems for a child if the pregnancy continued as well. So that certainly is an important test to do in the setting of recurrent miscarriage, because then that couple would then have genetic counselling, and we would then determine what its clinical, how significant it is, and they may choose later on to go down the path of a process involved with IVF called pre-implantation genetic diagnosis, where they actually check the embryos and try to find an embryo that's not affected to reimplant.
That was my next question. Yeah.
But even the evidence around that is still not, in terms of pregnancy outcomes, there's still a little bit of a question mark in terms of, I guess, broad population health, going out and screening all of these people for genetic problems. Is it really changing healthy pregnancy rates? Sort of the jury's still out.
Interesting. So would that cover, I suppose, that even other genetic screening as well that a lot of women are offered before doing IVF? I guess I'm thinking Mackenzie's Mission, things like that.
So now, it's a good opportunity to talk about Mackenzie's Mission, because that's pre-implantation. No, sorry, it's pre-pregnancy genetic carrier screening.
Yes, and this is what I'm thinking.
And so that's now a test that's available to all women considering pregnancy to look for common genetic conditions being cystic fibrosis, spinal muscular atrophy and Fragile X, that they are 3 common genetic conditions. And you can but the test is, at the moment, it's a couple of $100, but it's always going down in price. And I think you can access it, I think, soon, like through the public system as well.
They're campaigning to make it routine, though.
Yeah, part of routine testing. And so if you're a carrier, then they offer your partner the same genetic testing.
Okay.
It's a saliva test to see if then you could potentially have an affected baby.
Which means that the baby's life could be affected.
But then what? And then it's up to the couple as to what they do with that information as well. Because really that then brings us to like, okay, well, you find out that you're a carrier and so is your partner of, say, cystic fibrosis. And so you've got a 1 in 4 chance of having a baby with cystic fibrosis. But then it's important to emphasise that a lot of people now live long, healthy lives with cystic fibrosis. So is that going to change what you do? Fragile X is a different scenario where the outcome is, I guess, a lot more varied, but certainly spinal muscular atrophy, which was baby Mackenzie, that is a very, very challenging condition. I won't go into it in much more detail, but that couple, Mackenzie's parents, had really wished that they'd been able to find out that they were going to have an affected baby, and they wouldn't have continued with the pregnancy. And so I guess in that setting, then being able to access IVF and pre-implantation genetic diagnosis so that you put back a healthy embryo is what they've been campaigning for. But that's, it's just a side point. But so that's available to all women now that are considering pregnancy.
That's great. I didn't realise that was available now to everyone. Have we spoken about treatments?
No, we haven't.
How would you manage someone in early pregnancy who has had miscarriages in the past? Or what are some of the options available?
We can break it down a bit. Like I mentioned all of those different potential risk factors for miscarriage. So those things that I mentioned, the reason I specifically mention those are because there are treatments for those things. Okay, so there's lots of other tests that we can do, but we don't have treatments for them. So the question is, well, why look for it if there's nothing we can do that's going to change the outcome? Whereas those couple of things I mentioned, we can treat. So you can treat thyroid disease, we can treat antiphospholipid syndrome, or someone with SLE with Clexane and aspirin, which will mean that the placental tissue develops in a more healthy way. Uterine anomalies that you mentioned, Jaya, so we can treat fibroids, we can remove uterine septums. So I guess that's in terms of prevention. For women that we are seeing that have had previous miscarriage, one of the most important things in the first trimester is support and managing how they're feeling, like their anxiety in that early pregnancy. And so there's actually a bit of literature out there around having frequent review and frequent ultrasound for reassurance that the pregnancy is developing normally, because it is important to say that as common as miscarriage is, for most women, the most likely outcome of their next pregnancy is going to be a healthy ongoing pregnancy. But understandably, they feel very apprehensive about it. And so, say through our private practice, we would see women a lot more frequently and scan them for reassurance, and also through the public clinic, through the EPAS, like the early pregnancy service there, we certainly will be offering women more regular ultrasound just in the clinics, and they're not having to pay for an ultrasound, just for a quick check, reassurance, and actually that's like one of the most important things that we can do, because for actual prevention of miscarriage, there's really not a lot.
Just try and keep the environment as good as possible.
Absolutely. So in your practice, you probably see women in their early
I was
early
just thinking
trimester.
that early support, we will often see them weekly, I guess, until they have that dating scan, and we start pacing the appointments out a bit more, and then once they start feeling better too. But it's also that time where they can come in and talk about how they're feeling and have a bit of nurture.
Yeah. Do you know, I think it's excellent because in the traditional medical model, I think we've really undervalued care in that early time, like what we call the first trimester.
Yeah.
So, less than 14 weeks. It's all, and like women can really struggle during that time because often they don't want to tell people that they're pregnant yet for all sorts of different reasons.
Yeah.
And you don't know from looking at someone that they're pregnant. They're usually feeling pretty, like the nausea, vomiting, the fatigue, potentially cramping, potentially bleeding. They don't want to tell the world about it yet. It's a time when women actually need a lot of support, and particularly if they do miscarry.
And especially if people are not in touch with a regular GP that they feel comfortable with or they've built a relationship with, then if they're going through Bowen Health, they're not seeing someone until 14 weeks.
Yep.
So there's that gap there of going, who's looking after me in this period?
Yeah. The public hospital system certainly relies on GPs to do that early care, and like they do it so well. But yeah, as you said, a lot of women don't yet have a GP. So if you're thinking about pregnancy, it's a really good time to find someone that you feel like will care for you and support you and that you get along with.
And can you explain a bit about the EPAS clinic?
Sure. So EPAS, it's the Early Pregnancy Assessment Service. It's run out of Bowen Health. Most public hospitals have an early an early pregnancy service that look after women with pain and bleeding in early pregnancy. So up to 13 plus 6. Yeah.
So if someone's having a threatened miscarriage and they're not checked in with one of the midwives yet, they could come and see you there.
Yeah, so they won't usually be checked in with the midwives at the public hospital until about 16 weeks. So if they'd done a home pregnancy test, they knew they were pregnant, then I'd recommend that they make an appointment with their GP. Their GP will likely do some blood tests, confirm that they're pregnant, and depending on how many weeks they are, it depends how regular their period is, if they know what their how far along they might be, but otherwise getting an ultrasound, and then particularly if they've got some bleeding, to do an ultrasound at that time. But their GP, if there's any concern, their GP can refer them to our early pregnancy clinic, because we can also scan women in the clinic, do blood tests checking their pregnancy hormone level and try and give them some answers as to what's going on. Often in that really early time between, say, 4 and 7 weeks, it can be quite grey where we can't give women an answer yet as to, first of all, we want to establish that the pregnancy is in the right place, that it's growing in the womb, and so that their bleeding is a threatened miscarriage. But we also want to make sure that they don't have an ectopic pregnancy. If we're confident that the pregnancy is growing in the right place, then often it's just a matter of a bit more time, like often another at least 7 to 10 days, and then doing a repeat ultrasound to make sure that the pregnancy is growing properly. And some women can find this really hard because we can't give them an answer straight away, and it sometimes can be quite protracted, of quite a few ultrasounds over a couple of weeks to really be sure as to what's happening.
And so if they're already in touch with you, they can contact you or that clinic directly?
Yeah, the way the clinic's structured, they need to see their GP, and their GP refers them to the EPAS clinic, and the EPAS clinic is run by a midwife. Okay. So the midwife will triage the referrals, book the woman an appointment, usually give the woman a call to find out what the whole story is and tell them about what to expect as well when they come to the clinic. And often, if it's very early in pregnancy, we will do a blood test called a beta-HCG, which is a pregnancy hormone level. And sometimes it can be really helpful to do a couple of those blood tests, particularly, say, like just at least 2, 48 hours apart, because we'd expect that to double in a normally growing pregnancy in that time frame. So the midwife can sort of request those things before we've even seen the woman in the clinic. And then they are there when we determine what is happening and do that early counselling, and also do follow-up. So in terms of providing continuity of care, that's really important.
And Would you check progesterone as well?
Oh, such a good question. Do you know, I don't think it's not part of common practice.
Okay.
Like when women go to their GP when they think they're pregnant, other things being normal, they just check what's called a beta HCG. But certainly for women that are having like fertility treatment, ovulation induction, or have had previous miscarriage or are going through IVF, we check a progesterone level, because if that is low, we would then recommend that they have what we call luteal phase support, or we give them progesterone to try and help support the pregnancy. That might be a good segue into that there's progesterone has recently been approved by the TGA for the prevention of miscarriage in the setting of recurrent miscarriage.
Which means that GPs can prescribe it?
Yeah, they can. Yep. It's unfortunately not on the PBS.
Okay, so that wasn't a routine treatment before.
No. So
I guess in the fertility world,
yes. So traditionally, progesterone pessaries, which are like waxy tablets that go in the vagina, have been used a lot in IVF to support the embryo. Well, that's that traditional luteal phase support. But that was where that was the scope of using progesterone in the first trimester. But there's been some big trials done, and the outcome of that is that we think there is a benefit to giving women progesterone pessaries if they're having bleeding or pain and they've had previous miscarriage. So the previous miscarriage is what includes women in that group. Because we don't give it to everybody.
Yeah, I think the use of progesterone has just circled around forums, and a lot of women think of it as this thing that they should be on.
Yeah, if women are, I guess.
Do you know what I mean? Like a lot of people will come in and talk about it a lot more than say they would have 5 years ago, because a lot of people are using it.
I guess
in their IVF treatment,
in the IVF world. Yep. So we are going to start using that through our EPAS clinic. In the setting of, so for women that have had previous miscarriage and they come to see us with pain or bleeding, or if they've got other risk factors, like their age-wise or their medical history, if they've got other reasons that we'd be particularly concerned about their increased risk of miscarriage, then giving them.
But if there's a genetic problem happening, it's not going
to. The progesterone's not going to make any difference. No.
Yeah.
No. But that's why when you ask about a progesterone level, so if the progesterone level was low, then I guess there's more of an argument to put that woman on progesterone in the first trimester, or we use it up to 16 weeks and stop it at 16 weeks.
I guess if you're not going through fertility treatment, it would be assumed that your progesterone
it should be normal.
Yeah, high enough.
Yeah, and that you've got pregnant. Yeah. And I should say that it's quite expensive, the progesterone. So, yeah, it'd be about, like, not as a private script, it's about $90. I worked it out. So it's $90 for 41 pessaries or 42 pessaries. But then we recommend 400 twice daily. So that's 4 a day, and it works.
Wow.
So it's actually $90 for 8 days. And so then if you're on it for 10, 12 weeks, actually suddenly that's nearly $1,000. So watch this space.
Wow.
Yeah, I think it should be. I think there's definitely people advocating for it to be on the PBS. Yeah.
It's good to know. Have we covered what are some of the symptoms to look out for or that women might experience in a miscarriage?
Sure. Yeah. Okay. So I guess, most women would be familiar with pain. So crampy pain, like period pain.
So it's normal to have small amounts of crampy pain in the beginning.
Yeah, yep.
But I guess it's just a bit more significant or a bit more intense.
Yeah, and then if it was associated with bleeding.
Yes.
Yep. And that being said, bleeding is also very common in early pregnancy. Like 80% of women will get some bleeding in their healthy early pregnancy stage.
Yeah, it's really common. I see it all the time.
Yeah, so cramping and bleeding are both very common in normal, healthy, ongoing pregnancies, but obviously cause women to worry. But they're also early signs of miscarriage. A lot of women will also describe a lessening of their pregnancy symptoms. So their nausea, vomiting might get better, their breast tenderness might go away, their fatigue may improve. And because certainly some women don't get pain or bleeding, and the first that they become aware that they've had a miscarriage is when they go for a dating scan, or even their, the routine normal first scan that we do at 12, 13 weeks, and they've actually had something called a missed miscarriage, where somewhere along the line the pregnancy has stopped growing, but the body hasn't yet recognised that. So the pregnancy structure will just be there. Yeah. And that
there comes a bit of a difficult process of then scanning.
Yeah. So if it's, so if it's early, there's certain criteria that we use that tells us that it's definitely not going to be an ongoing pregnancy in terms of the size of the sac and then the size of the embryo and when we should see a heartbeat. Yeah. And so sometimes when it's really early on, so say a woman has just crampy pain and some spotting, but they're only 5 or 6 weeks and they do an ultrasound, they might be told, we can't yet tell you, what's going to happen here, because
we might not expect to see.
We may not be expecting to see a heartbeat yet, because we see a heartbeat from when the embryo is 7 millimeters. We'd expect a heartbeat, which is pretty incredible in itself when you think about it. Mm. And then there's also, in terms of the size of the sac, which is what grows first, we expect that by the time that's 2.5 centimeters, we should be able to see the embryo. So there's a few steps along the line that we use. And so if someone's very early, we can only see a small little structure there, that's when we'd need to repeat the scan in about 7 to 10 days to make sure it's growing like we'd expect.
And similar sort of situation if the embryo is looking a bit smaller than what we would expect.
Yes. For their dates.
Dates.
Yes. So if someone thinks, say, they're 8 or 9 weeks and they go and have a scan, and actually on the scan we're only measuring, small sac and maybe no embryo, I guess there's the question of, did they get their dates wrong? Was their period irregular? Or did they ovulate at a different time? And so are they actually only 4 or 5 weeks? Or is this actually a missed miscarriage and the pregnancy is not growing? And that can be a very difficult situation, because then we have to really wait and do another scan in a week and see if the pregnancy's grown, or it can be really tough. Yeah.
What about when the HCG is just rising slowly?
Yeah, so I guess that increases our suspicion that ultimately the woman may miscarry. Again, in that very early time, we do the beta HCG level until we expect we should be seeing something in the womb. So once the beta HCG level is over 1,500, then we should be able to see the pregnancy in the womb. Okay. And if we can't, then we are concerned about an ectopic pregnancy, or we suspect that the woman's completely miscarried. But that's when it's important we track the hormone level, sometimes back to 0. But if the hormone level is just hovering, so say it's like 600, then 2 days later it's 700, 2 days later it's 650, and it's what we call plateaued, then we call that a pregnancy of unknown location, and we'd actually recommend treatment as an ectopic pregnancy with a medication. Yeah. The medication's methotrexate. Yeah. That's probably beyond the scope of today.
So then if there has been identified that there's a miscarriage occurring or missed, I guess, is that in 2 different parts that I'm about to ask this question maybe, what other processes then? What happens after that's been identified?
Yep, that's a good question, Libby. So what we aim to do is be really clear with the woman that the diagnosis is a miscarriage, because I hear from a lot of women that they're sometimes left in the dark a little bit as to what the diagnosis is. And then so their options are either to what we call expectant, which is just natural, just wait, give it time and wait for the woman's body to recognise what's happening and manage that naturally. And what would happen is I'd counsel them to say I'd expect them at some point to start getting cramping and bleeding, And depending on how many weeks pregnant they are, that bleeding can be quite heavy. And the cramping back pain can certainly be much worse than period pain. But some women would choose to manage that at home and feel confident and comfortable doing that in their own home. The other option is something called medical management, which is a medication called misoprostol that we give women to take home. They take it at home and it brings on the miscarriage. Okay. And that's sort of the same scenario. The other option is surgery, and that's called a suction dilation curette. And that's a day surgery procedure. And usually, say at Barwon Health, when we've seen women in the clinic, we'd organise that to happen usually the next day or the next couple of days, depending on when we can do that. And that's a day surgery. So the woman's at the hospital for a couple of hours.
So if someone chooses to have their miscarriage at home, is there a point where they should be monitoring how much blood loss they've had?
Yeah. So I usually talk to women in terms of what to expect. There will be
there's a red flag.
Yeah, red flag. So there'll be a couple of hours, usually like 2 to 4 hours of heavy bleeding. And so by that, I mean changing a pad 2 hourly. Okay. But then it should begin to decrease after that peak time. And that it will be like a heavy period for, say, 24, 48 hours. But after they've passed like heavy bleeding, some large clots, it should begin to ease off. And then it should decrease over the next couple of days. So like a heavy period for about a week, decreasing, and then by 2 weeks should have stopped altogether. So for women that choose to do that through our EPAS clinic, the midwife would give them a call at 1 week and at 2 weeks. And also that women can have the midwife's phone number so that they can call them.
Oh, that's great.
Yeah, for extra support at any stage. Like they're just open during the afternoon, like the clinic hours. And otherwise, though, we recommend that women go to the emergency department because sometimes women do get very heavy bleeding. They can feel faint. The pain can be more than they can manage at home. And then we recommend that they come to the emergency department.
Yeah, I actually didn't know a lot of these processes. So it's actually good to know about.
Yeah.
The options, even just knowing you've got a midwife's number and you've got someone you can call.
Yes, yeah. And look, we're really trying to streamline it because some women that end up going through the emergency department, it's really important that we, I guess, smooth their journey through the different areas of the hospital and managing this at a really stressful and difficult, sad time for them. So, yeah, anything we can do to try and make that already hard process just a little bit easier.
I feel like we've talked a lot about some of the investigations we can do for the female, but how important is it to investigate both partners in those early stages or pre-pregnancy?
Or post-miscarriage.
Or post-miscarriage.
Yeah. So I think we probably alluded to it in terms of testing for the partner, in the setting of recurrent miscarriage, recommending that they do what we call a paternal karyotype, so the male partner genetic testing.
What about just a semen analysis?
I think that's more relevant in the setting of infertility.
Okay.
Yeah. Whereas in this setting, they've got pregnant, but then for some reason the pregnancy hasn't continued. And
would smoking influence it? Or we're looking more that would be affect fertility?
I think that's more of a fertility impact.
Okay.
Yeah.
Okay.
But I mean, just from a general health and well-being point of view, reducing and stopping smoking for both the man and the woman is definitely a good thing.
Yeah, absolutely. Any other resources that we need to talk about that women can access?
Yeah, absolutely. So I think, I guess from our medical perspective, I sort of see GPs at the centre of the woman's sort of care team. And then the GP can sort of do those basic first investigations, and they're the first port of call when the woman finds out that she's pregnant. They do the initial antenatal investigations. Even just if you're thinking about pregnancy, to go and have a chat with your GP about it, and they can talk to you, I guess, about taking, you know, the vitamins that you need to take beforehand, making sure that any medical problems are well controlled.
And counselling.
Yeah, counselling, I think we, again, I think at the sort of the mainstream system doesn't necessarily link in so well with psychologists, particularly with psychologists that specialise in pregnancy, that can be really helpful and supportive for some couples and women.
Often something they'll seek out themselves.
Yeah, yeah. Is there anything else that comes up in your clinic, like in the women that you're seeing? Any common questions?
A common theme is that the women can often feel like it's something they've done. I shouldn't have gone on that flight. I shouldn't have done that exercise.
Yep.
And really, when an embryo is, when it's the right one, it just works, doesn't it?
Yeah, absolutely. And that is so, we see that all the time as well in our clinic. And when, particularly for women that have had a miscarriage, I can see them counting back, like in their calendar, like, what did I do? Yeah, they go through every scenario. Coffee. Yeah. And really, there's so much guilt and shame. And I think as a society, we don't manage miscarriage very well. Like, we don't talk about, you know, I think so what we can do is talk about it more openly in our community and sort of normalise it as a part of pregnancy.
Yeah.
Because considering the numbers that you've spoken about.
Absolutely. And a lot of women say they only then realise it's so common when they experience it themselves, and then people around them share their stories, but they didn't know about that beforehand.
I think I see a lot of relief on women when I say, you can still have a coffee a day. You don't have to eat all organically. Like, your actual lifestyle generally really good.
Oh, absolutely. And that's one of the first things we say to women as well. Like, there is nothing you've done to cause this. Yeah. And even if there's nothing we could have really done to prevent it. Yeah. So even, we talk about progesterone, the numbers are still very small. There's really very little that we can do to prevent miscarriage if that's what's going to be happening.
So I guess that comes back to just supporting them again. Yep. Like I will always say to people, your next pregnancy is probably not going to be the same.
Oh, yeah.
You're going to feel anxious. You're going to be nervous. You probably need more extra scans.
Yeah.
And if you don't have access to them, you can pay for them.
Yep. Yep. Well, we're trying to make them more available through the public clinic.
That might change in the future, but for some people who are probably coming to see us more regularly are choosing to do that.
Yep.
Or linking in with their obstetrician earlier.
Yeah, yeah. And in private obstetrics, we do see women early, and we provide pretty intensive first trimester care. Like, we see women frequently.
How early would you start seeing them?
Oh, usually from 6-7 weeks. Do their initial dating scan and check in on, any medical problems they have, their past history, all of that. But
Let's say anyone who's been doing IVF, they're probably with someone till 6 weeks, and then they jump across straight to their
obstetrician. Yeah. But unfortunately, we that can't happen at the moment through the public system. But that's where the primary care physician, so the GP, really has a really strong role.
So finding a good GP that you connect with, is so important.
Yeah, yeah. And Jaya, I agree with you. I think, and to sort of end on a positive note, like, I always just try and emphasise to women and their partners that if they've just had a miscarriage, the most likely thing to happen in a subsequent pregnancy is for it to be normal and ongoing. Yeah, which is hard for them to imagine at that moment. Yeah. That's sort of what the numbers say.
Well, that's good to know, isn't it? Thank you so much for joining us today.
No problem. It's been really good to talk to you.
Thank you for listening. If you enjoyed today's episode, please share it with a friend, subscribe where you listen, or head to Apple to rate and review. You will find the show notes on our website, conceivethepodcast.com.au, and can follow us on Instagram at conceive_podcast, where you can also leave questions for future episodes.